Well, hello everyone, and welcome to today's Facebook Live with GBMC. I'm your host, Brandy Proctor. Well, May is Osteoporosis Month, so we're talking about everything from what causes osteoporosis to treatment and even prevention. So please ask any question that you may have. We are all learning here. I know I am. So let's welcome our guests from GBMC, Dr. Ruth Horowitz and Dr. James Johnston. Welcome.
Hi. Thank you.
Well, thank you guys for being here with us. So first, just tell the audience, what is osteoporosis?
So osteoporosis is a condition of the bone in which you have a general loss of bone structure, which increases your risk of fracturing. Bone is very dynamic, it's constantly turning over and remodeling, and in some patients, the loss of bone exceeds the formation of bone, and you get a breakdown of that small architecture in the bone. It increases your risk of little fractures within that bone, and it increases your risk of very large fractures. So we treat osteoporosis, or we try to prevent osteoporosis, because we don't want our patients to have fractures.
Right. How common is it?
Unfortunately, it's increasingly common. As our population is aging, we're seeing this increasingly more common.
Okay, so what really causes it?
So the bone is maintained by good health, by estrogen and testosterone that helps maintain good structure. When you go through menopause, you lose your estrogen on your bone, and that increases the rate of turnover, and then you lose that structure. There are other medical conditions that can accelerate that process, or even cause it in premenopausal or individuals or in men. Those things include things like certain medical conditions like rheumatoid arthritis or Crohn's disease. People who are on certain medications like steroids can have a higher rate of bone turnover, and that can accelerate that bone loss.
So what is the difference between osteoporosis and osteoarthritis?
So osteoarthritis is a disorder of the joints. Correct me if I'm wrong on this one. So you get breakdown of the joint structures. Osteoporosis is a disorder of the bone structure itself, so the long bones or the bones in the spine, as opposed to the jointed structures.
Okay, so how do you know, how do you diagnose osteoporosis?
Well, there are two basic ways to diagnose osteoporosis. One is clinically. If a patient presents with what we call a fragility fracture, that is a fracture that is one would not expect you to have a fracture given that event that happened. So falling from a standing height and fracturing is a fragility fracture. Having a spontaneous fracture is a fragility fracture. That would be a clinical diagnosis of osteoporosis. That's not a normal thing for bone to do. Or you can diagnose osteoporosis on a bone density. Okay. And this is an X-ray procedure that's done either at a radiology center, or certain physicians have that within their practice. And that measures the bone density in both the hip, the spine, and sometimes the forearm. And that gives you a representation of the different types of bone that we have in our body.
So once we see one of those fractures, then that's where you come in, right, Dr. Johnston?
That's right. So osteoporosis, it's a silent disease where you might not necessarily know you have it until you have a fracture. So oftentimes patients will present to an orthopedic surgeon for treatment of their fracture, and it's our job then to make sure they are evaluated and treated as necessary for osteoporosis. There are in the neighborhood of 2 million low energy fractures in the United States each year. There's a campaign called 2 Million Too Many. So there's a lot of these that occur each year. And it's important that if you're over the age of 50 and you have a low energy fracture, you should get tested for a DEXA scan. One of the analogies, my brother's a cardiologist, so one of the analogies I use is stress test. So in people who have heart disease, they may start getting chest pain or angina, and then you get your stress test. It's the reverse in osteoporosis, where you fracture first, and then we have to go figure out whether it's due to osteoporosis or from some other cause. They're in the neighborhood of 250,000 hip fractures per year. Each one of those can be devastating. And at GBMC, we treat about 150 people each year with hip fractures, and I see how that changes their life. It takes them oftentimes from a totally independent person doing everything they want to do to oftentimes needing a cane or maybe even needing assistance with daily living. So our goal, and Dr. Horowitz and I work closely together in this because it's a disease that requires a lot of different specialties, is to do everything we can to prevent those fractures so that people can live a nice life into their 80s and 90s.
So who should be evaluated for osteoporosis?
So any postmenopausal woman over the age of 65 or men over the age of 70 should be evaluated, or postmenopausal women who are younger who have some of these risk factors for osteoporosis, which would include a parent who had a hip fracture, a personal history of a fracture as an adult, someone who smokes, somebody who is thin or light, a thin body build, people who may have another medical condition that could contribute to malabsorption or low bone density, and people who are on certain medications like glucocorticoids if you're on prednisone, or if you're on medications to treat breast cancer like aromatase inhibitors, they accelerate bone loss. That would be a patient that you might want to screen at a younger age rather than waiting till 65.
So how do you figure out if somebody has osteoporosis?
So the main reason is through a bone density, main process is through a bone density study. This is a procedure where you lay down on a specialized table that does an x-ray of the hip, including an area called the femoral neck, which is one of the areas that fractures most frequently, and then looks at the spine. And if we don't have a spine or a hip that we can look at, we can also look at the bone of the forearm. And it measures the density of that bone, and it compares it both to the young control population and the individuals who are of the same age. And osteoporosis is defined that if your bone density has dropped below a certain level, that is defined as osteoporosis.
Okay.
If you have some degree of bone loss, but not quite as much, that's called osteopenia. And it's recommended that we treat patients with osteoporosis, and we consider treatment of patients with osteopenia if they have additional risk factors for fracture.
Okay, now I do have a question from
Yes.
Shelley.
Okay.
Is just what you said, is osteopenia the same as osteoporosis?
Can I actually take it? So it's important for people, all these terms are complicated and they're confusing for people. So osteoporosis is a lifelong disease. It's a silent disease. Osteopenia is a term that's used to define a certain bone density or a low bone mineral density. The best analogy I've heard is that your bone is kind of like a sweater with some rocks in it. The sweater, it's woven together. Those are the collagen fibrils, and the rocks are the density. The bone density test tells you how much of the minerals are in your bone. But there are certain people who have low bone mineral density or osteopenia, but are at extremely high risk for fractures. So we've actually expanded the definition of osteoporosis now. So people who come in with a hip fracture or a spontaneous spontaneous spine compression fracture are automatically assumed to be osteoporosis. People with low bone mineral density, like we used to call it osteopenia, who subsequently have a wrist fracture, proximal humerus fracture, pelvis fracture, should probably also be treated. So osteopenia and osteoporosis are confusing, but they're based on the DEXA definitions of how much mineral there is in your bone. But you can have plenty of mineral in your bone and not have good structure and have a fracture, and you may need to be treated for that.
True, exactly.
Okay, I have another question. This one's coming from Deborah. She says, what are the best exercises for strength and toning for osteoporosis?
So the first thing is what we call weight-bearing exercise. So swimming is not a weight-bearing exercise because you're buoyant in water. So anything that involves carrying around your body weight, so walking, running, aerobics, all of those things are weight-bearing exercises. Resistance exercise is doing exercise against a force, so bands, weighted exercise, machinery. Both of those are found to be extremely beneficial for bone formation. Then the other thing that we use for the prevention of falls, which is where most people end up having a fracture, is strengthening. So core exercises, Pilates, yoga, Tai Chi is an excellent exercise for strength and balance. And all those things together help prevent fracture.
I have two things. One, they've done some neat studies with astronauts. So up in space, those guys are exercising like crazy. You see them on the exercise bike all the time. Even exercising constantly, they still lose a tremendous amount of bone. They actually have increased calcium in their urine, and they tend to lose bone very quickly as the calcium pulls out of the bone because there's no gravity. So gravity is important. Getting up and doing weight-bearing exercises are really important. And the other thing that Dr. Horowitz mentioned was really important is fractures. So the hip fracture is often the end product of a lifetime of decreasing bone mineral density and increasing fall risk. So exercises that you do for core strengthening not only can help your bone, but they can make you stronger and decrease your fall risk. So if you don't fall, you don't fracture. So and our end goal really is to prevent fractures. So if you get up and do these exercises, it's going to help you both to make you stronger, and it's also going to help with your bones.
Okay, perfect. I have another question. This one also from Deborah. Now, how will I know if I have a fracture or damaged bone?
I'm going to let you go
Okay,
with that one.
so the best way is to get an x-ray. So you would, if you have, most people will present to the emergency room, an urgent care center, or a walk-in center, and we diagnose it that way.
Now, who is most at risk for the hip fractures? I know we've talked a lot about them, but...
So we see that the elderly are really at risk. Those people who have, decreased strength, decreased balance, people who fall, again, that same group of the postmenopausal women who are at it. Do you have any?
Well, so I was just at this meeting, and they had a great term, and they called it the silver tsunami. So about 20 years ago, we changed some of the recommendations about estrogen and postmenopausal. So we know that postmenopausal women are the highest risk. They tend to lose bone density very quickly as estrogen comes out of your system, and these osteoblasts are not making bone efficiently. So as these people are aging now, it's about 20 years since they changed those recommendations, they're all now 70s, they are at pretty high risk for fracture because their bone quality is diminished.
So who should be treated for osteoporosis?
The guidelines state that individuals who clearly have osteoporosis based on their bone density study should be considered for therapy. And if you are in that range that Dr. Johnston mentioned as osteopenic, which is not as severe a degree of bone loss, but you have additional risk factors, we can calculate how likely it is for you to have a fracture. There's a test called a Frac Score, which is an algorithm that brings together all your risk factors and your bone density and calculates how likely you are to fracture. And if your risk is high enough, those patients should also be on some sort of pharmacological therapy. Everybody should be doing enough calcium, enough vitamin D, weight-bearing exercise. That's a given for all patients. And even if you don't have osteoporosis, we should be looking to make sure we're doing that to prevent it.
The way bone is made, you have these two cells, the osteoblast making bone, the osteoclast pulling away. You're constantly remodeling, just like we remodel our house, and you're making new bone. If you don't have enough vitamin D and calcium, the bone doesn't become strong. So if you don't have those basics in your system, none of the medications will work and none of your exercise will work. So you really need to make sure that you have a healthy diet and get the appropriate vitamin D and calcium.
What medications are there?
Oh, there's lots of medications now. We have a good number of choices. The first class of drugs that we can use are called the bisphosphonates, and these drugs go into the cells that we call the osteoclasts. Osteoclasts are sort of like the Pac-Man that eat your bone up, and these go into those osteoclasts and it stops them from consuming your bone. There's an oral version and there is an intravenous version of this drug that you can take. They have great benefits. They have some potential side effects that we have to worry about. So we want to screen our patients and pick the right patient for these oral medication. There's another drug on the market called denosumab or Prolia. This is an injection that you give twice a year. And this drug works to prevent the cells that eat your bone up from forming. And they work very, very well. Again, certain patients should be picked for that. And then there's a class of drugs that are called anabolic drugs. These are the only drugs that actually form new bone. The other drugs I mentioned help you from losing bone, but the anabolic drugs are given by injection by the patient themselves on a daily basis, and this helps create new bone. And we use these drugs for 18 months to 2 years, and then from there you have to go to one of these other agents to preserve what you have now created. And they have a specific indication of which group of patients we should use them on.
Okay, now I have another question. This one is coming from Bernie. Do traditional osteoporosis medications make bones less porous but more brittle?
You want me to take this one?
Yeah, go.
Okay, so there's a class of medications that we describe called bisphosphonates. They include Alendronate or Fosamax and zoledronic acid and Boniva. A lot of these people have taken. And there are some known, very rare, but known side effects, and they have to do with that remodeling process. So the normal body is constantly making and exchanging bone and changing out your skeleton. If you remove the osteoclasts, which are the Pac-Man cells, you slow down or even stop that remodeling process, which is very important. If you had been losing a lot of bone, you want to stop that remodeling process. If patients are on these medications for a long time, you will develop some cracks or changes in your bone. And in very rare cases, patients have had what are called atypical femur fractures, which are fractures in this sort of upper third of your thigh, and it's because that's a very high stress area in your body. And those cases are very rare, but they do happen. The way that we mitigate that risk is by limiting the treatment to about 5 years and then usually doing a drug holiday. But that question is something we get a lot in terms of what are the risks of taking these medications. There's a very low risk of atypical femur fractures, and that could be what they were talking about the brittleness. But in general, your fracture risk is going to be decreased by 60%, and the risk of those fractures is somewhere in the neighborhood of 1 in 100,000. So it's extremely low risk, but it is a risk we need to talk to patients about.
Okay, can you talk to me about the bones that are on the table?
Okay, so this is a really good, it's sometimes hard. Can you guys see that on the, let's see, can you zoom in on that? So this is a really good example of what osteoporosis looks like. And this is a biopsy. It was actually a CT of a iliac crest. And you can see the cortical area here. And here is the cancellous bone. And people really have responded to this model. What you can see is there's trabecular bone inside, and it looks a little bit like a honeycomb. So you have the cortical bone, trabecular bone, and cortical bone. And this is taken from the iliac crest in a patient who has a T-score of minus 2.7, which is osteoporosis. And what you can see is you can really see through that bone. Mm-hmm. So the new guidelines are, and you can see if you were to fall or you might have a fracture. So the new guidelines are if you have a fracture, if you're extremely high risk for another fracture, you should be probably started on one of the anabolic medicines. And if you zoom in again, I'll show you. This is a patient, same patient, who now has been on 2 years of anabolic therapy. So osteoporosis, 2 years of anabolic therapy. And what you can see as you turn, you can basically see my hand and my coat through the osteoporotic bone. And here, the trabecular bone has thickened. And you can imagine if you were to fall on this bone versus this one, you'd have a higher risk of fracturing the osteoporotic bone than you would with the one with an anabolic. So once you're on these medications, now there are, there's always risks and there's problems and there's costs and things like that. So we wouldn't certainly do this on every patient, but in a patient who's had a fracture and we want to prevent more compression fractures and hip fractures, the highest risk patients, this is what we often go to first.
Okay, I have another question. This one is going to be coming from Shelley. Is osteoporosis reversible?
Yeah, you can see an improvement in bone density on these medications. Patients get very focused on the bone density number, and oftentimes with some of these medications, we don't see a huge improvement in the actual bone density number, but we see a very large reduction in fracture risk.
Okay.
So what we're trying to prevent is fracture. That's the end point. So all of the medications that we have to treat osteoporosis with will reduce your fracture risk. Some of them give a larger increase in bone density than other ones, but they all have a substantial reduction in that fracture risk.
Okay, I have another question. This one is coming from Laura. What can young people do to reduce their risk for osteoporosis in the future?
So that's a lifestyle question. So exercise is key. Okay. Staying active, there's weight bearing, the resistance exercises is key. Taking sufficient amount of calcium. I prefer that patient get their calcium in through dietary sources. There's lots of things out there that have calcium in them that we eat. Food sources of calcium are absorbed better than supplements, than pills. In a postmenopausal woman, we recommend 1,200 milligrams of elemental calcium a day, and vitamin D. There's a variety of different recommendations, anywhere from 400 to 800 to 1,000 international units of vitamin D. You get vitamin D through sun exposure in your skin, but most of us now wear sunscreen. We don't go outside as much as we used to very often. In my office all day long. So a little capsule of vitamin D taken once a day will help also help you absorb calcium and strengthen your bones.
Yeah.
Sorry, one other thing is not smoking and limiting alcohol. Those are
Absolutely.
big.
So we're talking primarily about postmenopausal osteoporosis, which is at menopause, estrogen's removed from the system, the osteoblasts are not working as well, you get increased bone. Somewhere in the neighborhood of 20 to 30% of people who present with fractures have some other cause, and that's why we really rely on Dr. Horowitz. Hyperparathyroidism, diabetes, people with malabsorption, all sorts of other causes. So in most cases, it's this postmenopausal osteoporosis, but there are other causes, and that's why we have to sometimes look around a bit.
So what lifestyle changes can older adults take to kind of decrease the risk of those fractures?
It's the same. It's exercise. You know, you want to, if you already have a diagnosis of osteoporosis, there are certain things that you want to avoid because you don't want to cause a fracture by doing something that would put your bone at too much stress. So, you know, I think Tai Chi is a great exercise because, again, that gives you that strength and the balance. It's not a very twisty kind of exercise. Yoga is good and Pilates is good, but there are certain exercises within those that you should avoid, which involve very deep and hard twisting and turning and forward flexion. That puts a lot of pressure on the bone. Some of the movements that we can do with our legs can increase fracture. So you may want to modify some of those exercises. You know, if you have osteoporosis, I wouldn't recommend you be a downhill skier or a rollerblader. But you know, aerobic exercises where you're not really doing heavy pounding, but all those exercises help. And then the calcium and the vitamin D, as I said.
Yeah, other lifestyle factors are in older patients, their vision may not be as good. They may have some peripheral neuropathy where they can't feel their feet. So a lot of times there's issues. They get up and they're urinating in the middle. You have to get up to go to the bathroom at night. So you want to make sure you have a clear path. There's no cords on the ground. Small throw rugs can be removed. Handrails in the bathroom. Simple things like that can prevent fractures, and so that's a lifestyle change that people can make.
Keeping the light on in the bathroom.
Simple things.
Yep. I've seen too many people break a hip because they got up to go to the bathroom and it was dark and they either tripped over something or just lost their balance.
But we want to really emphasize, so it's been shown that if you don't get up and exercise and move, we want people to be confident to get up and move. We want them to be active. Even if you are at a high risk for fracture, if you don't get up and move, your fracture risk your risk of falling is going to go even higher. So we want people to confidently get up and exercise. Okay,
I have another question. This one is coming from Elaine.
Can Alendronate be stopped after taking it for years? So absolutely. This is what Dr. Johnston was referring to. There were studies that were done originally on Alendronate that looked at long-term use of continuous use for 10 years or taking it for 5 years and then discontinuing it after 5 years. And the studies showed that after 5 years, if you discontinue it, your bone density will slowly decline, but your fracture risk in that first period of time does not increase. And with the realization that some patients do develop these atypical fractures that we were discussing, these fractures of the thigh, this seems to be related to long duration of therapy. So most of us, depending on the patient's risk, will give the medication for 5 years and then give them a break of it. We call that the drug holiday. And then follow the bone density and then restart therapy or give a different therapy as the bone density starts to decline. Now, in some patients who have very severe osteoporosis, some physicians opt to continue the Alendronate for longer than 5 years if they think that the risk of the fracture is much greater than the risk of these atypical fractures. So you have to look at each patient individually.
Okay, and so I know you said that you like for your patients to be able to kind of get those supplements through food and not pills. Does drinking milk reduce your risk of developing osteoporosis?
Yes, milk as a source of calcium is an excellent way to get calcium, and calcium does reduce your fracture risk. So, and also it's a sign that you're also having good nutrition. If you're drinking milk instead of a Diet Coke, you know, this is going to be a healthier lifestyle also.
Absolutely.
And so I saw one of the risk, or one of the signs, it said getting shorter is a sign, or back pain?
Right, so one of the risks, so what do you think is causing when an older person is kind of leaning over like this, or they're getting shorter, what do you think is causing that?
I don't know.
It's actually fractures usually. So part of it is you lose the disc space, they become drier as you get older, but actually they will often have fractures. So they think there's about 500,000 of these vertebral compression fractures each year. Most of them are silent, so you may not even know you had it until later. So there's it's kind of a newer test called a VFA, or vertebral fracture assessment, where you can use a DEXA scan and you actually get a lateral view of the spine. It's unbelievable how many people come in and have a DEXA and don't know that they had a vertebral compression fracture. And one of the best, easiest, cheapest ways to ask them if they have these fractures is asking about height loss. So that's one of the basic screening questions we'll ask.
Okay, so let's just do a quick recap. Who's at risk, what we should look out for, what we can do to prevent it.
So postmenopausal women are at risk, or men over the age of 70. Individuals who have concurrent other illnesses that might accelerate bone loss. People who have had a previous fracture. These are people who are at higher risk for having another fracture. What was the other question?
How do we prevent it?
We prevent it through adequate diet of calcium, vitamin D, exercise, not smoking, not drinking excessive alcohol, avoiding medical conditions that you can't do anything about, like rheumatoid arthritis, unfortunately. And then you evaluate it through a bone density. Your physician should also exclude other things that might be contributing to bone loss. There are other medical conditions like multiple myeloma that can cause fracture, and you want to make sure that you're not missing another medical condition in a patient who has fractures. So your physician should do a full evaluation of all the other things that could contribute to bone loss if you have a low bone density, and seeing your doctor regularly and staying healthy.
Yeah, I think I just want to recap. 2 million low energy fragility fractures is too many. We need to do everything we can to prevent them, and the best way to diagnose osteoporosis after a fracture is by getting a DEXA scan. So if you're over the age of 50 and you've had a low energy fracture, you should get a DEXA scan.
Absolutely.
That's incredibly important. That's going to guide your treatment and it'll help determine what your risk factors are. So.
All right, thank you. And if anybody has any additional questions, you can continue to ask them in the Facebook Live. Someone will get back to you. And if anybody wants to reach you, then they can go right to gbmc.org. Well, thank you guys so much for being here with us. Dr. Horowitz,
Yeah.
Dr. Johnston, appreciate your time.
Thanks
Excellent.
a lot.
Thank you very much.